Welcome back for another episode of Coding Matters, and today we'll be having a focus on trauma, and in particular trauma surgery, but of course trauma surgery always goes along with a lot of other key stakeholders in that service, and I'm delighted to be joined by Mr. Chris Dobbins. Chris, welcome, and what's your role?
Well, I am a trauma surgeon that works at the Royal Adelaide, and I'm also a medical lead that looks after the Surgery 1 program.
Excellent. Thank you for joining us.
Thank you.
So if you haven't seen Coding Matters before, we're going to talk through some issues particularly related to how we document and have quality coding for trauma-related admissions, particularly those that are unplanned, which is the nature of trauma. We're going to talk about how quality documentation and patient incomes informs that coding. We're going to be talking about some specific terminology and how that can make a really big difference to documentation and coding. We'll talk about manifestations and complications and how they contribute to complexity. So Chris, as a senior clinician and as a medical manager, how do you see the value of quality documentation and informing the coding?
Well, it's very important. A lot of our patients have multiple injuries. It's very important that we are able to identify all of those injuries and make sure that we have a management plan for each of those. The other thing that's slightly unique, a little more common with trauma, is that many of our cases also have a medico-legal aspect as well, so documentation is very important from those perspectives as well.
Yeah, absolutely. I think that's an element that probably is much more within your realm than some of the other specialties.
Yes, yeah.
If you're new to coding, there are some key points that inform a diagnosis-related group. And so you can see on this documentation the principal diagnosis, which is the reason or diagnosis that led to the admission. Secondary diagnoses are supporting diagnoses or those that arise during the admission related to complications. The different procedures, very relevant in this particular case, that the patient received to manage the principal or supported diagnoses, and the comorbidities, as these often influence complexity and complications. In order to qualify for a condition, we need to have some kind of assessment or diagnostic statement around the presenting features and physical signs and results that inform a diagnosis and assessment. We then have interventions that help support that diagnosis and a management or care plan to address those issues. Trauma is a very complex area, and there's very few of these patients would be regarded as simple admissions. They often present with multiple different issues. I mean, how do you get your head around these patients? They're coming thick and fast with many different issues. How do we frame that?
Well, I always take more of a head-to-toe kind of approach.
Mm-hmm.
I find that's easiest for me, and most of my colleagues do that. So, you know, when we start with trauma, we start with a primary survey, which is looking really at the hemodynamics and the vital signs of the patient, stabilising those, and then we go through a head-to-toe examination and try and identify all the issues as we go from the top to the bottom.
And I suppose with that complexity, it's really important that we have a very clear structure to the way we document,
yes,
so that at every stage we're not missing things.
Yes.
It can be, I imagine, easy to get really focused on the kind of flagship injury, and
yep,
maybe we miss out some of the minor things that later become much more significant.
Yeah. The other aspect of trauma that is slightly unique as well is that we don't always pick up all the injuries on the first inspection, so to speak.
Mm-hmm.
We'll often do a tertiary survey after a couple of days and see if we identify any other smaller injuries as well.
Sure. So I suppose at the point that someone is being admitted or within the first 24 hours, ideally we want to get all of these points on the screen. So what was the actual incident? What was the mechanism of injury? That's quite important, because that can help us predict the complications and things that might not be overt when they first present.
Yes, yeah. It also helps us to get an idea what the likely injuries are likely to be. So for example, if you have a motor vehicle rollover, you're likely to, you're at increased risk of having cervical spine injuries, for example.
That makes sense, yeah. And then there will be some conditions apart from the flagship injury that were present and required intervention before they've reached our doors. I think particularly of those finger thoracostomies and those other kind of at the scene or roadside interventions to stabilise the patient, that we then build on the management of them in a more definitive way once they present. So documenting what those injuries are and how they've been managed before they reach our doors is quite important.
Yes.
And then once they've arrived, being clear about how they got here, the supports they required to reach us, and what kind of multidisciplinary team involvement has been required. So these people, I've been to those events where they arrive, and there'll be MedStar or our ambulance service, there'll be the ED team, there'll be the trauma surgery team, anaesthetics, intensive care, and that's the minimum. And then on top of that, depending on the nature of the predicted injury, vascular, orthopaedics are often quite commonly involved.
Yeah, orthopaedics, plastics, vascular are probably other surgical specialties are very commonly get involved in these injuries.
Absolutely.
Spinal from time to time as well.
Yep. And so being clear about who's doing what role and which part of the injury they're managing and what their plans are is very important, because in the chaos of everyone turning up, sometimes things don't get documented well, but it is worth the investment of time.
Yes.
And then we can also see that some issues arise later on during the admission that maybe weren't very clear at the time, and being able to define whether they are likely to have been there at the time but unnoticed versus those that are complications that have occurred later in hospital or due to some of the interventions is really important. And then in terms of surgery, that's a realm that I'm very unfamiliar with, haven't gone into theatre for some time.
Yep.
How do we write our surgical descriptions so that they're rich with that detail so that we can code?
Yeah, we will always write a operation note at the end of the procedure, which sort of details all the steps that have been taken and the interventions that have been done. And within trauma, we often do an immediate operation where we would have a patient in theatre within 1 hour.
Mm-hmm.
Often those circumstances is a sort of a truncated operation, almost called damage control operation, where we're just really aiming to get in and get out, control sepsis, control bleeding, and then plan for a more definitive operation at a later date, usually after 24 to 48 hours. Occasionally the operations aren't quite as acute as that, and they would be done within a few hours. And then there would be other injuries which wouldn't usually be managed by my team, but by some of the other teams like orthopaedics and plastics, where an operation is required but potentially could be done the next day.
Sure. Something that we touched on previously in the general surgery side of things is being really descriptive with what is found during surgery.
Yeah.
You're opening these people up or using scopes and describing what can be seen, not just what is abnormal, but what is normal, I think is particularly relevant in trauma surgery, especially when you're thinking, did that hematoma arise later, or what could it have been there but just not noticed at the time?
To be honest, when we do a trauma laparotomy, we actually take a stepwise process to go through that, and we inspect all of the organs essentially from the top all the way through to the bottom.
Very thorough.
Very thorough. I mean, we need to be, especially if we're in a situation where we can't get a CT scan first, if they are very unstable. So we look at the diaphragms, the stomach, the small bowel, the liver, the spleen, go all the way through, inspect the lesser sac, inspect the retroperitoneum on either side, and have a look in the pelvis. And we deal with things as they happen.
Yep.
Usually in those circumstances, we are in a damage control situation, and we wouldn't be looking to do a definitive anastomosis, for example. We'd be just controlling sepsis and controlling bleeding, essentially.
Come back later.
Yeah.
So here's an example. Hopefully this represents something that would come through your doors pretty often.
Yep.
So a 55-year-old woman who's admitted for 4 days with a fractured ankle associated with dislocation and a head strike. We can see the mechanism of injury is documented as falling from 2 stairs whilst carrying the washing from the back porch to the clothesline at home. There was a head scan that ruled out internal brain injury, and then proceeded with an ORIF, presumably with the orthopaedic team. So there, that gets put into a coding of a simple fracture with a reimbursement of $28,000. Now, the same patient, if we had clearly documented the head strike with scalp laceration, and then had some minor intervention for that, presumably just some wound care and ensuring that it's clean and no infection is there.
Maybe some sutures.
Some sutures, yeah, maybe a bit of a glue.
Maybe.
An ED, yeah. Then that actually changes the group that it gets coded into, and that becomes a multi-trauma event. Even though it's exactly the same person, the same management, because of the documentation, we're now being reimbursed almost double what was there before at $58,000. And so it just shows that we're investing the money in these patients, in their recovery, and if we're documenting well, we're more likely to be able to be reimbursed for the money we're actually spending on their recovery.
Mm-hmm.
Here's a bit of a cheat sheet for a lot of commonly associated conditions. This is in a lot of areas of surgery, but particularly relevant to trauma surgery. Which ones for you really stand out as areas that we need to emphasise?
There's a few here. Firstly, sepsis and shock, fairly common in trauma, particularly when patients are unstable when they first arrive. Acute organ failure is part of that, so often patients are in ICU and require some ICU
circulatory support,
yes,
respiratory support, etc.
Exactly. Hematomas are extremely common in trauma, not surprisingly. Thrombus and embolus are also quite common in trauma, and occasionally patients, when they first present, may have a pulmonary embolus, for example. After the initial bleeding settles, trauma patients are in a procoagulant state, so tend to clot.
Mm-hmm.
Post-traumatic amnesia is also very common in our patients because head strikes are common, and we do tend to treat closed head injuries much more seriously than we had in the past, and this is where the post-traumatic amnesia testing is quite important.
Absolutely. I can see that would be easy to overlook if you're focusing just on that flagship injury and their surgical recovery, but noticing a lot of these things that may become more prominent during the recovery phase.
Yep.
So here are a lot of documentation examples where, as medical professionals or our other colleagues, we might document something that we're making assumptions about the interpretation of. So I think Chris and I might write hemoglobin 85 and on anticoagulants, and we would assume, or we'd interpret that as anemia due to their traumatic injury or due to intraoperative losses.
Yes.
But if we don't actually write that, it doesn't get coded as that.
Yeah. Acute blood loss is very common in trauma.
I would think so.
Kind of comes with the territory.
Yeah, and then likewise, hypotension due to septic shock, hypotension due to hypovolemic shock. These things are there. We often maybe overlook documenting them, but if we document them, we're providing a better basis for ongoing quality care of our patients, and we're supporting coding as well.
Absolutely.
A really common one would be desaturations. We look at that and we think hypoxia, and what we should be writing is acute respiratory failure, ideally type 1 or type 2, in this case probably type 1. It's just taking that extra step and that few extra 5 to 10 seconds to document it, and then it becomes codable and it contributes to the complexity.
Yeah.
Do you want to talk us through this example?
Sure. So we have a 60-year-old man admitted for 15 days with a C2 cervical fracture. He was a passenger in a car versus four-wheel drive, a head-on collision in a shopping car park. When he arrived, his blood pressure was 90/50. He looked dry. He was treated with some intravenous therapy, and he subsequently had a spinal fusion. This has been coded as minor complexity, which seems amazing, actually.
Amazing, yes.
$26,581.
Surely there's more to it than that.
Yes, so we can do better than this. We can document in this manner. 60-year-old man admitted for 15 days with a C2 fracture. Patient looked dry, postural hypotension due to dehydration documented, for which intravenous therapy was charted and given, and the patient subsequently had a spinal fusion. This is coded as intermediate complexity and pays $36,500.
That's quite a lot of extra money for writing the word dehydration.
It is, isn't it?
Isn't it? And we could do even better. What are the additions in the third example here?
Well, let's have a look. 60-year-old man admitted for 15 days with a C2 fracture, further complicated by paralytic ileus and atelectasis due to surgery requiring extra physiotherapy. He had runs of paroxysmal AF, which was treated medically. Patient subsequently had a spinal fusion. This is coded as major complexity, $62,752.
I think it just goes to show, those big pieces are the same in all three examples of this patient, but those extra details of what happened after and during the admission are really adding to that complexity in a significant way.
Certainly are. That's almost 2.5 times the value of the minor complexities.
Absolutely. Probably more reflective of the amount of resources and money that have been invested in that person's management.
Yep.
So I wanted to talk specifically about mechanical ventilation. I think this is an area that we don't do so well on and is kind of an easy win, a low-hanging fruit, if you will.
Yeah.
So we need to document specifically when they were intubated and in the circumstances, and then ideally when they're extubated as well. And that data is often recorded, but in areas that are not commented on, so we need to link that with the management.
Yep.
And so if someone is intubated at the scene, or perhaps during transit, or perhaps in the emergency department before they go to theatre, that has a lot of different significance for the coding and in part for the management of the patient versus someone that is perhaps electively intubated by the anaesthetist immediately preoperatively. It's different because we're really intubating under different circumstances, and that will then contribute to the complexity. I was also surprised to learn how the complexity is hugely influenced by the duration of intubation, depending on how many hours, specifically some of those ones like 24 hours, 96 hours, and the amazing 336 hours, very, very specific. And let's have a look at the difference here. This 79-year-old gentleman who was admitted for about 3 weeks, his principal diagnosis was a T1 and T2 fracture, and he had ventilation initiated in the operating theatre and continued for 14 days. So that totaled a mechanical ventilation period of 335, just below that cutoff. So that's obviously someone who's very unwell and required a lot of support, and that gets reimbursed at the tune of $101,000, not a small amount of money. Now here, if they had been intubated on admission in ED, and then they continued, that's added a few more hours. So the circumstance is different, and now we've ticked over that magical 336-hour period. So both of those mean we've gone from major complexity to major complexity with prolonged intubation, and that adds $80,000.
Wow.
It's amazing that just that extra hour is apparently worth $80,000. That's just where the line is drawn. So just be aware that the line is there and document accordingly.
Yep.
Allied Health often feature very heavily in your patients.
Yes,
who are some of your key partners, and what issues are they addressing in your patients?
We have a lot of input from physiotherapists that they need to get patients up and mobilising. Speech pathologists as well. Often, they get involved doing the post-traumatic amnesia testing as well as other things. We've got dietitians. They help us manage the nutrition of our patients because often they become malnourished fairly quickly. Often they can't start eating for a long time. And these patients do decondition pretty quickly as well.
Absolutely. I mean, a lot of the surgical recovery alone, plus a lot of your patients are spending a number of days and even weeks in intensive care.
Yeah,
and
if
on
they're wards as well.
Yeah, and if they're ventilated as well, they're not using a lot of their muscles. So I imagine that the physio for recovery and discharge planning is so key. And again, as we have in some of the other videos, just emphasise some of those diagnostic terms like deconditioning. So rather than just saying get the physio to see, if you document patient appears to be deconditioned related to surgery or related to injury, physiotherapy to address deconditioning, physiotherapy to address sarcopenia, dietitian review to assess malnutrition or malabsorption. Those diagnostic words and terminology really unlock some of the coding potential that's there. This is all happening, the management's going there, we're investing this money and resources in the recovery, and the coding can then support that.
Yeah. The other group that often get involved in our patients are psychology and social work as well. There's often a mental health aspect to a lot of the patients that come in, and a lot of patients actually develop mental health issues as a result of their traumatic experience and injuries as well.
Yeah, absolutely. I'm sure it can be very confronting to be so vulnerable and be, sometimes come away from these instances with disabilities as well.
Yep.
So just to summarise some of the things we've gone over, we've talked specifically about multi-trauma and trauma surgery and how we document in a quality way that informs good quality coding. We've been very specific about some of the reasons for presentation, the mechanism of injury, the associated management pre and during their hospital admission, and we've talked about complications and manifestations of the injury that then all inform complexity. Specifically, we've emphasised the need for documenting the circumstances of their mechanical intubation and the duration of that. Thanks for joining us, Chris.
Thank you for having me.
I've learned a few things, and hopefully this will be helpful to you watching at work or at home. Thanks.
Thank you.